Hello, good evening. Today we are going to discuss together nice topic, which is surgical techniques and technology. Okay, very nice, interesting topic. We will enjoy discussing it, especially for general surgeon. Okay, so let's start as usual by reading the question and discuss the answer together. Is the screen clear and voice is clear?
Yes.
Okay, so we can make it also like, no, keep it like this. Okay, so who will start, Dr. Baida? Can I start?
Okay. Thank you. Which one of the following sutures would be most appropriate for closure of the scrotal skin following orchidopexy in a 3-year-old boy who is otherwise well? As he is a child, so we need to use absorbable suture. It's 50 Vicro Rapid.
Okay.
Okay.
All of here is?
It's non-absorbable. Polypropylene is synthetic monofilament, non-absorbable. And the 30 Vicro is very big for this skin closure for this wound. And 30 Silk is multi-filament, non-absorbable. And so to overcome the problem with the removal of the suture for this baby, we use the absorbable type. So we have either Vicro or Vicro Rapid. Actually, first when I studied previously, I was confused between the Vicro and Vicro Rapid. But it's what the difference between them?
Okay, Vicro Rapid is less rapidly or less time to stay in skin and dissolves more rapid than Vicryl, the normal Vicryl. This one I think takes 6 weeks, but Vicro Rapid takes less time. Any comment from our dear surgeons, our seniors? Dr. Magid, Dr. Muhammad, Dr. Az, our surgeons, open your mics.
I think Vicryl Rapid is the best answer because it also doesn't make and it is rapidly absorbed, less infection. As my colleague said, it cannot. We are not going to remove and make no pain for the child. So 50 Rapid is a perfect answer.
I think. Sorry, can I think
Vicryl
it is not less infection because it's multi-filamentous.
But it's a little no I know that it's a little infection than the normal Rapid, the normal Vicryl. What I think so, yes, but the absorption time is more fast.
Absorption
to the skin
after 4 months.
It is
after 4 absorption is after 4 months. 4 months.
4 months.
I think absorbable is more fast, stay less, and I know it is multifilament, but
yes, it's
means Rapid.
Yes.
It will stay less in the wound, so it will be less infection. That's what I
know. Yes, and by the way, we use Vicryl Rapid now in closure of most of our operation, even post laparoscopy, simple wounds, and because it's less infection, and I think dissolve is more rapid. For normal Vicryl, I think it's about 6 weeks. I think to stay normal Vicryl.
Yes.
Yes, I think from 6 weeks to
Half-life
2 months.
Yes. Yeah. Exactly.
Okay.
If you would like to, Dr. Rami, to add about the type of suture in this scrotal incision, maybe it not come. I don't know if you would like to make it mattress.
We just have this schedule, this table I shared now. We have some. You'll find some few questions, and by the way, most questions about types of suture will be repeated. in the exam because, you know, many are not surgeons or general surgeons, and sometimes don't know many about this suture, but it's very, very important part to be, by the way. However, what we need to know in this table is the first one, which is the silk, which is the biological braided, and we little use it. We little use it nowadays. Okay, sometimes we use it to close a drain, chest tube, or any extra abdominal drain. Okay, catgut and chromic catgut, you will not have any question about it, even in part A or part B. Go for PDS and Vicryl and Proline and AC bond. Okay, most important are the first three. You have two synthetic. Okay, just a minute, please. Settings, waiting room. Okay. PDS is very important.
In
synthetic.
Vicryl, sir, polyglycolic acid, Vicryldexone, in special point, why they write that it should not be, this suture should not be used for skin closure?
Okay, we said that it is mostly used now. By the way, some surgeons using normal Vicryl, but now if it is provided for you Vicryl Rapid, it will be better cosmetically and for the wound than normal Vicryl. And most hospitals or most places now use Vicryl Rapid for these skin wounds, especially when you are not going to remove the suture material. They use Vicryl Rapid. Okay, they are enough time for the wound for closure with less reaction than Vicryl, normal Vicryl.
By the way, the Rapid always undyed, and you find in special points for the Vicryldexone, it has good handling properties as the dyed form of this suture should not be used for skin closure. Now, blue Vicryl, if you met this blue Vicryl dyed one, the Rapid is always undyed, white color.
Exactly, colorless. Exactly.
Yeah. Color.
And that's why, by the way, when you go for this will be in part B exam, you have a station for suturing, and you have a station for knot tying. He will give you in the exam the closed pack of the suture material, and you have to give a full comment about it. You have to know this is colorless, this is violet, this is Vicryl, this is silk, this is, and you have to know is it synthetic or biological. In the exam, you'll find only silk is biological, and you have to know it is monofilament or braided, and you have to know the difference between both of them, which is preferred and which is someone has some advantages and one has disadvantage above the other one. Okay, so Vicryl has a good memory, but and easy manipulated, but it has a high rate of infection and reaction for the skin. Okay, infection rate for it and the reaction to the skin is higher. On the contrast is the monofilament, which will be proline, like proline. Sorry, like proline. Yes, it will be difficult to manipulate, and you have to make more ties. But at the same time, it is less reaction for the skin. Okay, so we have. I'll tell you the most important points we use here. First one is silk. You'll find that we are using it in making some like Radivac or chest tube, some tying external device like drains. PDS, okay. We would like to use the big one, especially the two sides, to close the abdominal wall. The midline abdominal wall, especially we take a full size Sorry?
Sir, I think silk is also used for tying vessels inside the body cavity. Correct me if I'm
Not.
wrong.
You will not find any questions like about using the silk inside the body here. We will go through all the questions. We'll try to finish all the questions today.
Okay, sir.
Okay. Just if anyone just
It
raise hand
was
to
used
stop.
before, but now obsolete. Yani no one
Before
using now.
10 years ago, we are using
Yeah.
only silk of
Yeah.
tying the base of the appendix and tying the cystic
And,
duct and
yeah.
most
Ureterotomy and urethral anastomosis was used bladder prepare before. Now not used at all.
No, I didn't use it for more than 6 years or 7 years.
Yeah.
Okay, and I can't find it even in some hospitals. And we use other material to tie a drain.
Exactly.
Okay, PDS. Now we use the big one. We use it to close the abdominal wall. Okay. We use 2 or 1 size to close the abdominal wall, especially when you are doing a midline incision for exploration or any operation, and they take the abdomen in one mass. It is thick and long time. It takes long time to be absorbed, and also it is less reaction, and it is more long suture, so you can use it for the abdominal wall. We use the 3-0 sometimes in making visceral anastomosis. They like it, and this question is very common in the exam. Doing intestinal anastomosis, we use about 2-0 or 3-0 PDS to close any anastomosis. Okay, so we have visceral anastomosis and mass closure of abdominal wall. Okay, Vicryl. You will find no questions here. You can use it for Vicryl to close, but sometimes we use it to tie the cystic duct, to tie the base of appendix, to ligate some vessels inside the abdomen sometimes. So we use it practically in these issues, but here you will find no question about using Vicryl. Proline, when you want to use a synthetic monofilament, permanent, not absorbable, suture. Okay, we use it in vascular anastomosis. Okay, and sometimes also we use it for cardiac problem. If you have a cardiac wound, they use a non-absorbable suture like a Proline.
Also, abdominal wound, and hernia repair.
Sometimes fixation of mesh, but now I can tell you that they use for mesh something like the PDS or normal Vicryl to fix the mesh, and the Proline started to be less and less, especially new types of mesh. Okay, started to be less used inside the body to stay a longer time, sometimes making like stitch sinus and something like that. Sometimes they don't like to use it now. Okay, I'm talking about the most uses you will face here. The AC bond, no, this sometimes used by ortho to fix big tendons and something like this. You will find no questions to be asked here. So silk, fixation of drain, PDS, abdominal wall and visceral anastomosis. Vicryl, I don't think we have some question about it here, but we will go through and see maybe one question about subcutaneous tissue, closure of subcutaneous tissue. Okay, and Proline, we said we used for vascular anastomosis or vascular repair and cardiac repair. Why? Because it is less thrombogenic. Less thrombogenic. If we used thrombogenic agent like
and also Rami, the Proline is I think is the only one has the least sizes. Yes.
The least. Sorry, the least I can't hear you. Okay, and polyester AC bond. I think we. Yes. Okay. Least what?
least size least يعني sizes in calipers في البولين for
Yes,
the
maybe
vasculars.
because we
Yeah,
have
yeah.
all zero. Now we have 0, 0, 12 and something like
7
this. We can
0.
use for
Yeah.
up to 0, 0, 12 even in some
Yeah.
vascular. But I'm thinking about the idea. They like proline in vascular surgery because other braided sutures is thrombogenic for the vessel, but proline no. So they use proline. If anyone worked in vascular department, they're using proline for any anastomosis or any fistula or anything like this. Okay, we took long time about the first question. Thank you. We want to pass because we have many questions like this, but this is the first one. So next will be this, and this is the difference between absorbable and non-absorbable, and how to choose the size and the braided and monofilament, as we said. Next question, Doctor Aisha.
A 53-year-old cleaner is admitted with a fall. She is hemodynamically stable and a CT shows a massive retroperitoneal hematoma. She is on warfarin. What is the most appropriate course of action? Hemodynamically stable, CT shows retroperitoneal hematoma. Infusion of factor 8 concentrates, infusion of vitamin K alone, infusion of human prothrombin complex vitamin K, infusion of human prothrombin complex to know, infusion of pectritzel. I warfarin, the antidote of warfarin is vitamin K, and option B, vitamin K.
Vitamin K alone?
Yes, I think alone.
Okay, anyone has different answer? How to reverse warfarin? I think this is in physiology. We want to revise physiology again. How to reverse warfarin?
Yes, we should stop warfarin and start heparin.
Sorry?
For preoperative or what?
No. I want to reverse warfarin if a patient taking warfarin and got a warfarin toxicity, and we want to reverse this warfarin.
We give fresh frozen plasma and vitamin K, but it's not fresh frozen plasma here in the options. So I think infusion of human prothrombin complex, because it's the target in fresh frozen plasma and vitamin K.
Okay, let's remember this in physiology. Warfarin acts on extrinsic pathway.
Extrinsic pathway.
Heparin intrinsic pathway. Okay. This how to monitor PT or INR. How to monitor heparin. APTT. Okay. How to reverse warfarin? First option is vitamin K, but it works after 24 hours. So if you are in emergency, it will not give you good help.
Fresh frozen plasma.
The second one is
fresh frozen plasma.
prothrombin complex concentrate. Okay. The third option is fresh frozen plasma.
Okay.
Okay. This is in order. If you are in emergency, you have to go for fresh frozen plasma and give vitamin K, so you can start from the second day if you don't have fresh prothrombin complex concentrate enough. So you can start on to continue on vitamin K. Okay, but vitamin K is good. But if you have mild toxicity and you are not in urge, or a little bit high in warfarin level, or a little bit high in blood, his blood coagulability, okay, or bleeding or some problem like this. But the best is prothrombin complex, followed by fresh frozen plasma. But heparin We reverse it by
Protamine.
protamine sulfate. Okay, clear? So here is the best. Okay, about this.
Infusion of vitamin K.
Prosthrombic complex and vitamin K.
But the patient is hemodynamically stable.
Massive retroperitoneal hematoma.
And it is an emergency also.
Exactly. You want to stop. You will not start after 24 hours for vitamin K to start.
So, sir, why not option D?
Okay.
Only prothrombin complex.
Not alone. We give both together. If you have both together, give them both together first.
Sorry, I didn't understand. Can you please repeat why not option D?
Why not option D?
G.
Because we have option C is option D plus option B. And this is the best.
Okay.
Best to start both together. Vitamin K will start working after 24 hours. So it will help you in the second day to continue if you don't have enough prosthrombic complex to start. But prosthrombic complex will provide you with coagulation factors at the same instant you give it.
Okay.
Okay.
Okay,
Clear?
sir. Yes, thank you.
This is blood products. We will study it more in physiology. Okay. Next question. This some I don't know. Anyone knows about the level of evidence? You studied it before, so you can go with this question. Can raise hand. This is some topic was called level of evidence of any decision. Anyone can raise hand? So Muhammad. Perfect. Okay, go for the question.
One of the senior surgeons in the hospital advises as to the best management of Merkel cell tumors of the skin in which she has a special interest. What level of evidence is this?
The senior surgeon in the hospital advice.
Unfortunately, I don't know.
Okay. It is just a topic you have to know, and this is in UK and some rules and some sort of management and some I should be related to statistics by the way, but it is I found it here by the way. So D4. Okay, let's go for level of evidence. This is 5 level of evidence. Let's discuss about level of evidence. Okay, what's level of evidence? It's a very easy issue. If you are in hospital and you want to check or to do or to practice a special procedure or a special decision or a special way of doing an operation or doing chest tube or you want to manage, this comes with 5 stages. First stage, level of evidence 1, which is the obtained from systemic review of all relevant. Let's go for some words like this. Just a minute. Okay, let's go like this. If you go for all relevant randomized controlled trials, so your evidence is 1. Okay, if your procedure or your decision is obtained from a systematic review for all randomized controlled trials, so your evidence is 1. Like what? Putting a mesh in inguinal hernia repair. All relevant randomized trials say that is the best way to do a mesh to in an oblique hernia to put a mesh. Okay, or in obstructed hernia infected, you shouldn't put a mesh. This is something all relevant randomized controlled trials say this is evidence. So it is number one. So you are following the generous information about this. Let's go for number two. For at least one properly designed randomized controlled trial. Some like I'll put the mesh without fixation. I'll put the mesh without fixation. Some trials said if you put it without fixation, sometimes okay, it is fixed, no problem. But it is not, level of evidence is 2. It is just at least one probably randomized. So if you found all, it will be 1. If you found at least 1, it will be 1. Level of evidence 3. Okay. What's called, you'll find in the question, pseudo randomized controlled trials. Pseudo randomized controlled trials. Okay. This is the key answer here. Number 4, which is a case series or case report. He will tell you this, doctor, according to a case hospital report or a case report in some area, they can do this procedure by this way. So level of evidence is localized, it is regional, not something like international or something approved by a higher institute. So it is a case series or case report, and you are doing a study first time to choose 50 cases to do the mesh in such way and see the results. So this is proof of evidence is 4. 5, this is your personal opinion. I'll do this. It's my way. And you know, no one other did this. Why do this? I think it will be nice and I want to try it. Did you see it before? No, but it's upon of my mind. I want to, level of evidence is 5. It is your personal opinion. Okay, so 1 is all. Pseudo randomized, okay, no, you will have no question about pseudo randomized. Okay, this is all statistics. All statistics. If you want to go for statistics, it's a very big issue. And we have few questions in the exam, about 5 questions. And about the trials, it's maybe only 1 question. And we discussed it a few days ago, about 2 weeks. And maybe we give a revision during solving the question. But put in your mind, all randomized control study will be at least one properly designed randomized control study or trial. It will be 2 pseudo randomized. You'll find no question about pseudo randomized. You'll find a question about a case series. It will be evident 4, or a personal opinion or a personal decision. It will be 5. Clear?
Clear.
Okay, keep with the first and second and third and fourth. It's very easy, by the way, and we found many questions about it. Next question.
Thank you for this nice explanation, Dr. Ram.
Thanks, Dr. Muhammad. Was Dr. I think it is Dr. Aisha. You didn't participate. Dr. Jeffrey, you can participate after them. So it would be Dr. Baida, Dr. Aisha, then Dr. Jeffrey. Okay, Dr. Aisha, تفضلي.
A 59-year-old lady undergoes an exploration of the common bile duct and insertion of a T-tube. Which of the devices listed below would be the most appropriate for this purpose? Latex T-tube on passive drainage, propylene T-tube on passive drainage, propylene T-tube on suction drainage, latex T-tube on suction drainage, Primrose drain. I think it should be latex T-tube on passive drainage, because latex promotes fibrosis, and usually passive drain is applied to the T-tube instead of suction. A, I think.
Okay, I think this is the opinion. Let's go for chat. A and A. Any surgeon had different answer. You have here polyproline, and we don't put T-tube proline, T-tube proline. We don't put Primrose drain, even we don't use. go for latex, GT tube. Sometimes we do it with passive, sometimes we do it with suction, but with common bile duct exploration, we use latex with passive drainage. No, yes, we asking about fibrosis, but here we asked latex because of fibrosis, passive drainage, and suction drain. Passive drainage for sure to give time or to give a chance for closure of normal or passage of normal bile. But if we put suction drain, the bile will never stop draining. Okay.
And when we use
Dr. Ayman. Okay.
When we use metallic, here speak about the T-tube or about drain?
T-tube.
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 So
drain, yes,
when we use metallic T-tube.
Metallic T-tube?
Yes.
We don't use metallic T-tube.
In CBD.
We don't use, we use metallic stent, you mean? Not the
yes,
tube.
Metallic stent.
No, stent, this is another.
This is for ERCP. This is not for, this is for non-surgical, this metallic, and this is for cancer. But the latex tube is the best answer, which usually we are using.
Exactly. We have questions about metallic stent. Okay. We use a T-tube when you do exploration in open surgery or maybe exploration by laparoscopic surgery. You can put a T-tube and to drain outside. The stent, we use it. Yes, percutaneous. Sometimes no, but you have to do it in open or laparoscopic surgery and drain outside the body. Okay. The stent, we use it for two options. Okay. The stent, endoscopic ERCP stent application, we use it for two options. First option is stricture, whatever it is malignant. This is the first and most common, but like cancer pancreas, we use it. Or sometimes post-operative, like you are doing excessive diathermy or excessive manipulation for the cystic duct, or putting the clip very close to the common bile duct, and some stricture happen maybe due to excessive diathermy use or a very tight suture close to the CBD and so on. And the other option, you do it when you have a bile leak post-operative and you do an ERCP and you find there is a leakage from the cystic stump or slipped clip or slipped ligature, and you find some leakage. A stent is put across this leakage to decrease the leakage and make the normal bile passage till the open is closed. This is the two options you have to put when you use a stent by ERCP in bile duct surgery or biliary surgery. Okay, clear?
Yes.
Okay.
So stricture or leakage for the stent, but T-tube, this is for open or laparoscopic surgery in CBD exploration. Next question. Dr. who? It will be Dr. Ayman, Dr. Ibrahim, Dr. Mahbub. Who's next? Dr. Ayman, تفضل.
Yes. Which of the following local anesthetic preparation would be most suitable for an 18-year-old male undergoing unilateral Zytek procedure?
Ingrowing toenail.
Ingrowing toenail?
Yes, this is that procedure. What will you use anesthesia for this patient?
Ring block.
Ring block.
Lidocaine alone.
Which one from the three? Lignocaine alone.
Yes.
Lignocaine alone.
Yeah, we can't
Anyone
use
has different answer?
And artery.
Because?
Adrenaline it causes ischemia in end artery.
Especially in extremities and toes and fingers. We don't like to use adrenaline. When we use lignocaine with adrenaline?
for example, inguinal hernia.
Bloody tissue or bloody skin or
tissue.
bloody area. Like what? Scalp.
No idea. Scalp, yes.
Scalp. Yes. When you are going to suture a scalp, you can add adrenaline because the bleeding is so high and so profuse. So you can use adrenaline. So we have two questions here about adrenaline, when to use it, by the way. One, he will ask you about an extremity like growing toenail or finger or a toe problem, and you have to choose only lignocaine 1%. Okay, and you can't add adrenaline because it is not the best choice. Because sometimes some people I know they add for prolongation. So when they are going to do an operation like ganglion or something like this, but it is not preferred and it is not used in UK. Okay. The other thing, when he asks you about a scalp wound, what is the best choice for you? It will be lignocaine plus adrenaline. Okay.
Okay.
Clear about this question? This important two questions you will face here.
Doctor, in practical, we use 2% lignocaine.
Whatever you have, it depends on the dose, and we are going to discuss the dose. You will apply your dose, or you will use a specific dose for everyone. If 2%, you will use maximum dose of you. It will be about 10 or 10.5 milli maximum dose. But when using the 1%, your dose you can up to about 21 milli per dose. Okay. We didn't talk about anesthetic dose before, yes? Okay, very common questions in exam, part A and part B, the local anesthetic doses. Okay, it's very easy and very nice. You can put in your mind. You have 3 important anesthetic agents, which is lignocaine, bupivacaine, and Prelucane. Okay, the most common one coming in the exam is the first one is lignocaine. Your dose, plain dose, you will give for the patient is 3 milligram per kilogram. But if you add adrenaline, you can increase your dose up to 7 milligram per kilogram. Okay, bupivacaine, you can give 2 milligram both plain dose or with adrenaline. You can't increase. Okay, and this is the maximum dose. Above it is the toxic dose. The third one is Prelucane, which is 6 milligram per kg, and you can use up 9 milligram per kg if you add adrenaline. Let's go. How could I know? Because in the exam he will ask you if you have lignocaine 1%, how many milli you will give for the patient? What is the maximum dose for a healthy person? So you are calculating your maximum dose according to 70 kilogram patient. Okay, let's go as a maximum daily dose for local anesthetic like lignocaine 1%. It is 3 milligram per kg. So if is 3 milligram per kg, so if he's 70 kilo, it will be 210. Roughly here he said it 200. You make it roughly 200. Okay.
Means
so
20 mil.
Okay, let's go for means 20 milli. Yes, it means 20 milli. How he uses it's 20 milli.
How we use it?
It's yes. He make it should be 21 milli, by the way. If you have 1%, keep it in your mind like this. If you have a concentration of 1%, you will divide over 10. Okay. So if you have the maximum dose is 200 milligram. Okay. So you have 10 milligram per milli. So how many milli you need? 200 milli over 10, so you need 20 ml. Clear? Not clear. Okay.
Okay.
I have percentage 1%. So I have 10 milligram per milli. Okay.
Okay.
This is roughly the 10% what resembles. If I
Yes.
have 2%, I have 20 milligram per milli. I go for the dose. I have my maximum daily dose is 3. So 3, so I have 3 by person 70 milligram. So it should be 210 milligram. 200 milligram, it resembles how many milli? I'll divide by, if it is 1%, I'll divide by 10. So I have
milli?
21 ml. Why 7 milli? I'll divide over 10.
Over 10, okay.
200 or 210 over 10. So I'll have 21 ml. But if I have the 2%, so it will be 210 over 20. So I'll have 10.5 ml maximum dose. This is the plain dose without adrenaline. With adrenaline, I'll do like this. With adrenaline, this is very important in part B. And most commonly, he will ask about this. Most commonly, he will ask about this. He will tell you how many milli will give if you have lignocaine 1%. You tell him, I'll give him a maximum dose of 20 ml. But if with lignocaine, you will go for a 50 ml. Let's go with lignocaine 1%. Okay, so I have 10 milligram per milli. I'll give with lignocaine, I give 7 milligram per kg. So I have 7 by 70 kilogram. So I'll give 490 milligram. Okay.
Okay.
Consider it here, just approximated it to 500. 500. I have 1%, which is 10 milligram. So I'll divide this over 10 to give me 50 ml maximum dose. Clear?
Yes, sir. Thank you.
It's clear,
Yes.
I think,
Can I have,
now.
yes, I have
Can you have what?
a question, please.
Okay.
So we have, for example, we have lipoma 3 cm and we have lipoma 10 centimeter. What we will do? We give
You'll do.
how we give a local anesthesia.
If you have long time, how you give local anesthesia? If you have long time in the procedure and you expect some bleeding, you can add 7 milligram, or you can add adrenaline, so you can have more higher dose of toxicity. It depends. You have this lipoma and this lipoma. This lipoma, it will take about 4 or 5 centimeter milli. Okay, this lipoma will take about 12. You still in the 20 ml. You still didn't go for the toxic dose.
Yes.
You still in the less toxic dose. But if you give the patient, you have one question we have. He gives the patient about 30 ml, and the patient start to have some toxicity. Anyone remember what is the reverse of if you have lignocaine toxicity?
Intralipid.
Interlipid 20%. Exactly. Interlipid 20%.
And it causes lignocaine side effect or complication. It causes arrhythmia.
Exactly. And sometimes it's used for treatment of arrhythmia, by the way. Okay, clear? This is the most question you will be asked about. The same, Perioperative 2%. How percent? So you have 5 milligram multiplied by 10. 5 milligram, 5 milligram per milli. 70 kilogram person by 2 milligram. So you have 140 over 5. He just approximates this to 150. So he give up over 5. He give it 30 ml, which is this number. Clear?
Yes, clear.
Clear, I think. It needs some training, and then in the exam you will be asked about the most common ones, which is this, so you can keep it.
Rami,
Next question. Yes.
how many cc we give intralipid to reverse the toxicity of lidocaine?
I can't remember exactly, because most questions he not
Uh-huh.
he don't go for how much you
Yeah.
give intralipid, but this is a treatment for this, that they give intralipid for toxicity. You will not be asked about this one. You just need the antidote for it.
Thanks.
Okay. Next question. Whose turn? Who's raising hand? Many. Okay, Dr. Baidat, go.
Okay. 28 years old man undergoing an incision and drainage of axillary abscess. How should the wound be managed? Primary closure, delayed primary closure, packing with alginate dressing, packing with gauze, skin graft. As there is an axillary abscess, so we exclude the primary closure. And delay primary closure should be performed within 24 hours. We have abscess, so it's contraindicated. And it's highly exudate, so we need to take off all the fluid that's collected within the wound. So need highly absorbable dressing, and the gauze is not highly absorbable. Skin graft not suitable, so we go with packing with alginate dressing, as alginate used for the highly exudate wound. C.
Perfect, Dr. Baidat. I think this is clear. We don't close a wound for abscess, and we use alginate dressing. This is absorbable dressing. Okay, we use it for abscess, and when you use an abscess, and this is very important in the station of abscess drainage in Part B station. It's very important, because he will ask you what is the type of dressing you use. You'll ask, you'll tell him alginate dressing. Alginate dressing.
Sir,
Yes.
what we use in alginate dressing?
Just please raise hand, so sometimes I can't hear you. Just raise hand so I can. Okay. What
we use in alginate dressing. What kind of dressing it is?
What is this? Alginate dressing? You asking about the alginate dressing itself?
I think it's a starch type, so it is very dry. The alginate dressing. It comes in
This
multiple
is a type.
forms.
This is This is a type of dressing called alginate dressing. That's type of absorbable dressing. They just you put it,
like
absorb.
Sofratul.
Sorry.
Like Sofratul.
No, not like Sofratul. No. It is a dry dressing, absorb toxic and exudate from the wound, not to keep in the wound. If you put a non-absorbable dressing like Sofratul or anything, the exudates will be stayed inside the wound between the changing dress.
Excuse me, it's made from some types of algae that's hydrophobic, so it is very, very dry. So it's contraindicated with dry wound because it causes ischemia. It's absorbed all the water and exudates that present within the wound. This is the alginate dressing. It comes in multiple forms, either ribbons or sheets, or even like powders. You can be placed within the wound.
Okay, thanks, Dr. Zubaida, for this nice information.
Okay.
More deep information. Thank you. I think it's clear now, Dr. Jeffrey.
Yes, yes, sir. Thank you.
Just know it is a type of dressing.
Yes, sir.
Okay. Yeah, let's go for the next question. Okay, anyone listen? Dr. Aisha, go.
Sir, then what is the difference between U-sole and alginate dressing? Are they both same type
Again,
of dressing?
what's the difference between what?
Dressing with alginate and dressing with U-soles. That's also the type of dressing we use for open wounds. Like we soak or
No
wash in
difference.
U-sole so
No
that
difference. No difference for our work, for our daily work, for our any work. We can sometimes put any dressing we have. Okay, but in the UK and in the eMRCS and according to our scope, this should be standard for use in abscess. And in part B, you have a big session, a big station called abscess drainage. This is procedure skills. And you have to say you use any tissue or any cotton piece and put it inside the wound at the end of your station and say, I am putting an alginate dressing. You have to hear this from you, the examiner. Okay? Just go.
Yes.
They are using some protocols. This is some protocols. You have to know the right basic protocols for use, and then you can decide what to do. If you send me in UK, they are all using this. No, but this is the standard protocol for using in apps.
Okay.
Okay. You're welcome. Okay. Who's next? Who can go for?
Yes.
Dr. Ayman or Dr. Ibrahim?
Yes, me.
Anyone, Dr. Ayman, Dr. Ibrahim?
Go, Dr. Ibrahim.
Okay,
Okay, Dr. Ibrahim, go.
Which of the sutures listed below would be most suitable for suturing the femoral artery following an embolectomy? In vascular, we use polypropylene, so I'll choose B, 50 polypropylene.
Okay. I think it's clear now, yeah?
Yes.
We don't use Vicryl, which is polygalactine. We don't use silk, and we don't use polyester. Okay, we use Prolene for vascular surgery. Make it so simple. The question in the exam will be so simple. He will tell you a vascular anastomosis, IVC repair, aortic repair, and so on. It will be any 50, sometimes 60. This is according to the size of the artery you are, or the vessel you are suturing. Sometimes you use 70, 80, 10. Okay, this according. So here he is asking about the embolectomy, so he using 50. Next question. Okay, Dr. Ayman, تفضل.
A 5-year-old boy developed a persistent fever following an open appendectomy for gangrenous appendicitis. On examination, he has arrhythmia of the wound and some abdominal distension. What is the most appreciated course of action? So he has
what you doubt here?
He has wound infection,
erythema, and then abdominal distension. That's appropriate. Most appropriate action you go here. Your general surgeon?
Me, pediatric.
Pediatric surgery. It's your question. Child 5 years and you have appendectomy for this, and you find a problem in the wound and the abdomen. What you doubt? or what you want to make safe or to make sure?
I doubt for infection, wound infection.
Wound infection or collection?
Paralytic alias.
Collection.
Collection.
Yes, but if he didn't mention that you have abdominal distension and the abdomen is lax, and you have the wound is some redness in the wound or swelling of the wound, so you may think about surgical site infection. But he mentioned here for you have an abdominal distension, so you have an ileus. So you have an ileus, you doubt for leakage, collection, slip ligature of the appendicular base, or abscess collection. So you go for what?
For ultrasound scan.
Ultrasound scan, exactly. We always want to go for CT first in pediatric. We don't like to make them projected to high X-rays and high radiological rays. So we prefer to do ultrasound as a first or the most appropriate course of action in this patient. Before you go for, you suspect wound infection, you have to make sure that you don't have any abdominal collection, any right paracolic gutter collection or Morrison gutter collection or pelvic collection, and the infection of the wound is just restricted to the wound. Is it clear?
It's clear.
Okay. Okay, next question. Orthopedic. Who's orthopedic? Okay, Dr. Mahgoub, go for.
72-year-old woman fracture her distal radius. A virus block is planned to facilitate reduction of the fracture. Which of the following agents should be used? 1% Lidocaine, 1% Lidocaine with 5% Prelucane mix in 50-50 mixture, 1% Perioperative, 1% Lidocaine with 1 in 2,000 adrenaline and 200,000, and 1% Prelucane with 1 in 200,000 adrenaline. The answer is C, Prelucane. For Bayes patches, for Bayes block.
Okay, keep it in your mind because it's very common in exam. Very common in exam. Bayes block is very common in exam and very common in recalls. Very common. It come maybe 2 exams from the 3 exams if it didn't come in the 3 exams. One of the most important questions that come about anesthesia is Bayes block for fracture radius or for Cullis fracture. Okay, in old patient because they don't like to use general or regional anesthesia, they use the Bayes block, so they gave it Prelucane 1%. Okay, keep it in your mind like is it. Don't ask about any exploration for it. Okay, next question about blood transfusion. Who's next? Who go for?
Yes.
Okay, Dr. Ayman.
In which of the following operation would the use of the salvage device be permitted? Everloas esophagectomy, revision arthroplasty, revision abdominal aortic aneurysm, mastectomy and litmus dorsi flap, excision of osteogenic sarcoma. So can I get help, Dr. Rami?
What is the exactly, Dr. Baida? Okay. The salvage device is to collect blood intraoperatively and to use it again.
Yes,
to give
yes.
the patient. Okay, this is
Yes, I
type of
remember.
blood transfusion when you don't have a reserve for blood and you need blood transfusion. If it is a clean, non-septic and not malignancy, or for any malignancy operation, you can use the blood by this salvage device and give it again, re-infuse for the patient. But you should not have any malignancy or any infection. So go for the question. Evaluate malignancy.
I go for revision. Yeah, we have Ever Louis.
For hip. Yes.
Ever Louis for cancer. We cannot.
Okay.
Abdominal aortic aneurysm, there is infection. Mastectomy, it's cancer, ductal carcinoma.
Cancer cells.
Yes. So I will go for B.
Go for
B.
Okay. Exactly. B. So this is no infection, no cancer. Okay. No infection, no cancer cells.
Okay.
Next question. Okay, Dr. Nago. Dr. Nago, you raise hand.
Sir, I want to ask about the previous question that the surgery for aortic aneurysm is also not contaminated. Why can we not use that cell salvage device for aortic aneurysm surgery?
No, this is for recurrent, for graft infection. We can use for abdominal aortic aneurysm, but this is surgery for graft infection. So you have infection, you can't use it.
Oh, okay,
Clear?
sir.
Clear?
Yes, sir.
You have here 3 cancers and 1 infection. Okay. Next question. Who's turn? Who's ready? To Mahgoub.
Okay. Which of the following substance is commonly used to sterilize endoscopic equipment? For endoscopic equipment, we use glytaldehyde, D.
Exactly. Okay.
Yes.
This is a topic about sterilization. Okay. By questions we know, and I think 2 questions only in the exam. He will ask you about the sterilization. Okay. We have some external topics, but I think I didn't prepare it today about some questions, but it is all the exams, which is eMRCS, about ways of sterilization. But most common you'll find in the exam this question. Endoscopic treatment and some laparoscopic equipment, we use glytaldehyde. Okay?
Yes,
and others. Sorry?
Gamma irradiation for industry.
For?
Industry equipment.
Industry equipment. Autoclave for reusable surgical equipment.
Yes.
Autoclave, reusable surgical equipment. Okay?
Okay.
Okay, I think we have more clear issues in eMRCS. I think I have some questions of eMRCS. I'll try to collect it and send in the group. It gives you 3 or 4 scenarios and 5 or 6 types of sterilization. More clear than nowadays, because before they have 1 or 2 big scenarios about sterilization and when they have extended matching questions. But here when it started MCQ, they have 1 or 2 scenario maximum. And most of them come about this. Use of autoclave and use of endoscopes and laparoscopic equipment. Okay. Level of evidence. Who can go for this question? Dr. Baida. Okay.
Okay. An orthopedic surgeon make a modification to an operative approach for total knee arthroplasty. After he has completed 25 cases, he stops and review his patient's outcome. He published the data. What level evidence is supplied by this type of data?
So it
there is a case report,
case study.
case history, sorry. So it is
Case
level
series or
4.
case study. Exactly. I think it's clear now about level of evidence, yeah?
Yeah.
Clear, yes. Again, 1 is all relevant randomized controlled trials. 2, at least 1 probably designed randomized control study. 3, forget about it, this is pseudo randomized. 4, a case study or case series. And 5 is your personal opinion. Next question. Dr. Aisha. Okay, Dr. Ayman or Dr. Mahbub, who's ready? Dr. Ayman.
Yes. A 73-year-old lady present with an ulcer overlying her medial malleolus. It is painless and has been present for 4 months. She has for 4 months. She has edema of the lower limbs and her ABBI measure 0.9. What's the best management option? So she has venous ulcer.
Yes, exactly.
And ABBI, it's not so severe, so we can go for compression bandage. Or
okay, you choose A or B.
Choose A.
Exactly. Don't be hesitated. You choose A. If you have a patient with a venous ulcer, sometimes it's venous bleeding ulcer. What you do is that you make a compression bandage about the venous ulcer to decrease the congestion and decrease edema around the ulcer. Okay, that's why he have to mention for you here that the ankle brachial pressure index is 0.9, which is almost normal. Okay, which is almost normal. So he tells you that the patient has no ischemic changes or any distal vasculopathy, that you can't use compression. But if he told you that he had a vascular problem or distal vasculopathy, like ischemia or chronic ischemia, or EBBI is low, so you can go for non-compression bandage. Non-compression bandage, okay?
And compression is contraindicated here in severe cases?
Non-compression, you put it just patient has both some venous problem and the patient has peripheral ischemia. You can't make compression. You don't have question about it, but just I want to deliver the idea for you that the patient has normal arterial supply and they have an edema together with the venous ulcer. With edema and venous ulcer, you can go for compression bandage. We don't do grafts for venous ulcer except it is very big. It's very big. Sometimes we use graft, but small grafts, no, we don't use for the. And even for short time grafts, we don't use any grafts. Next question, doctor. We need at least finish half of them, please. Dr. Mahgoub.
Yes, a
No.
68-year-old man undergoes a wide local excision of squamous cell carcinoma from the lateral aspect of his nose. At the completion of the operation, the alar cartilage is visible. What is the best method of closing the wound? Interrupted 3-0 silk, local rotational flap, splint thickness skin graft, vacuum assisted closure system, full thickness skin graft. This is in the face, the best thing for basal cell carcinoma, so I need to do rotational flap, local rotational flap.
Exactly. Exactly. We use flap. Any facial defect, okay, during use any lipoma, any tumor, any mass, especially near the face, near the bone, you make a expansion or extension graft, or like a rhomboid graft. You can do rotational graft and so on. And here is the most common one is local rotational flap. We use it for facial wounds or facial skin defects. Okay, who's next? Forget about this statistic question. We need to explain about the mean and median and mode, and so forget about it today. Okay, next question. Who's ready?
Yes.
Okay, Dr. Ayman.
During pelvic lymphadenectomy, the common iliac vein is injured and there is profuse bleeding. What is the best course of action? Clamp the vessel to gain a better view, and delegate, occlude the bleeding point with digital pressure. Use diathermy at high coagulation. Apply Surgicel to the site and wait bleeding. Apply digital pressure on the vessel. So profuse bleeding, so I think we have to do ligation. Yeah, I think we do a repair with the polypropylene. B. Answer is B. I will go for B. Hello, Dr. Rami?
Sorry, I'm saying, will you ligate the common iliac vein? It's unlogic to ligate it. Okay, so we use suture it
I
using...
go for repair, suture repair.
Okay, repair 5-0 or 2-0. You have 5. B and C and E. B and E.
I will go for 5-0.
Exactly, 5-0. Use 5-0 to close the venous wall is small, so you can go clamping is injurious to the vein. Exactly. You'll just compress the vein, the opening of the vein, and then you prepare for 5-0 to suture the vein. And that's all. Okay, 2-0 is very big to suture a wall of a vein. Okay, next. Dr. Baida. Then Dr. Aish, she left. I think Dr. Aisha left. Yes. So Dr.
Okay.
Baida. Okay.
73 years old man undergoes a laparotomy for mesenteric infection. An extensive small bowel resection is undertaken. A planned relook laparotomy is scheduled to occur in 24-hour time. What is the most appropriate closure strategy in this situation? Mass closure of the abdomen, opaque Jenkins rule using 2 PDS, application of Bogota bag, mass closure of the abdomen, opaque Jenkins rule using 2-0 PDS, mass closure of the abdomen, opaque Jenkins rule using 2 nylon, mass closure of the abdomen, opaque Jenkins rule using 2-0 nylon. As the operation is redo, so we cannot close it directly. So we use a Bogota bag and leave it for open under subsidence and for of edema. Then after that, we'll close it by the mass closure and Jenkins rule. Okay. So I choose 2. The Jenkins rule is 2 يعني شلون نقول لك إياها إنه 2 centimeters sorry 2 millimeters from the incision and 2 from each suture.
Jenkins is 1 centimeter.
1 centimeter.
1 by 1, sorry.
So
1 by 1.
if you want to close, the wound, okay. If you want to close the wound after you have your second vision or second redo, relook,
Okay.
what will you do? What will you use?
Use a 2 PDS.
Non-absorbable.
2 PDS. 2 PDS. No, we said PDS is an absorbable suture, but it takes about 6 months to be absorbed, and it's completely enough, and it's a big and long suture material and strong and has half-life about 6 months. Before, we was using together Vicryl and Proline to close the midline incision for any exploration, just for a support, but you can, sometimes you have some restriction to close with Proline, like in pediatric and young age, who still didn't reach their full growth, you can't use Proline. Okay, so now PDS is used instead of Vicryl or instead of Proline. Okay, this is a synthetic monofilament suture material and have a big size and have a long length. Okay, clear? Okay, so we here, as the patient is going for a second or a relock, we use a Bogota bag, okay, to close the wound. Next question. Okay. Keep it here, Dr. Muhammad.
Which of the sutures listed below would be most suitable for subcuticular closure of an inguinal hernia repair wound? 2-0 polyglycotin, 2-0 silk, 6-0 polydixon, 3-0 polydixon, 1 polydixon. I think 3-0 polydixon.
Perfect. Yes, this is practical work. We don't use Vicryl now. We don't use silk. And then we are choosing between 3 PDS, which is 6-0 or 3-0 or 1.
We have suture, what we call the monocreel. Is it the same PDS or different?
No, not the same. Not the same.
Monocreel,
PDS,
which type?
Monocreel. Monocreel, I think it's the
Dixon.
Dixon. I think the Vicryl Rapid is monocreel. Monocreel. I think is a Vicryl Rapid. I think the second name of Vicryl Rapid is monocreel. No, not it. Yes. No. Not the same. But he didn't mention even in all our schedule about monocreel, by the way. He is asking about the PDS. Maybe the PDS is the monocreel, but this is the other name of it. But we don't use it for subcutaneous tissue. We use it sometimes also, yes. But keep with the PDS. Monocreel, I know it's a monofilament. That's why I'm thinking this is what maybe the PDS, yes. Maybe, but not. No. I don't think this is a PDS. PDS is completely different from it. Keep with PDS. Forget about monocreel.
Okay.
Keep it with B. You have nothing called monocreel in part A or part B. Okay, you'll find nothing about monocreel. You have the vicryl, you have the proline, you have the PDS. And here, this is subcutaneous tissue for hernia. We use 3,0 PDS. Who can go for next one? Who? Okay, Dr. Mahmoud.
Okay, 63-year-old man with end-stage osteoarthritis of the hip is due to undergo total hip replacement. The skin has been prepared and antibiotics given. What is the single most important modality to reduce the risk of infection? Laminar flow theater, exhaust suits, skin shaving on the ward, total body scrubbing of the surgical team, extended antibiotic chemoprophylaxis as routine. The most important, I think, will be laminar flow theater.
Exactly. This type of some type of sterilization or keeping the theater is sterile is the laminar flow theater. Okay. Don't have many questions about this, by the way. Maybe you'll be asked about shaving, skin shaving. This is this is not preferred in patients. Just not preferred in patients. Preoperative, to make shaving of the skin, you have to use the single-use hair. What's called hair chelation. Okay. Antibiotic prophylaxis is better for cases with infection or cases you are going for a prosthesis. You have to give a preoperative, or we say sometimes this is the clean contaminated operation. You are going for cholecystectomy, you are going for appendectomy. Okay, so you have to go for sorry?
Tourniquet use also.
Maybe, yes, exactly. So you can go for a preoperative antibiotic use. Sometimes using even the any prosthetic material. That's all questions about preoperative protocols to decrease the infection. Okay, next question.
Okay. Which of the following visceral anastomosis has the lowest risk of anastomotic leak? You may assume that all are constricted in ideal circumstance. So we have visceral anastomosis. We like to use BDS. Or he asked about.
He asking about the least likely to have anastomotic leak, lowest risk of anastomotic leak.
About the method. So we have stapled, we have hand swing, we have stapled colorectal anastomosis with lobe ileostomy. We have stapler colostomy with defunctioned with lobe colostomy, and hand swing is esophagogynostomy. So I think it's guidelines. I don't know.
Okay, he just wants to tell you here that esophageal B, esophageal and colonic anastomosis has a higher rate of leakage than small intestinal anastomosis. Okay. He wants to give you this idea. Is the proximal ileum as the best, and then he tell you that anastomosis in the ileum or the small intestine is better and has the least chance
Lower
of
risk.
leakage than lower risk than colonic or esophageal.
Doctor, what about stablet and hand swing?
Here is not asking about this to tell you what is the difference between both of them. Both of them has a good anastomosis, and both of them has its default. Maybe with hand sewing, some leakage may happen if you are not expert, and some stapling if you are not perfect in stapling, and you are not putting mucosa to mucosa, are not making tension for the wound, or you just making both ends of the tissue have a weak vascularity, so leakage may happen. He wants to ask here about this idea. He wants to ask about this idea. Rectal esophageal surgery has high stress and osmotic leakage than small intestine. This is the idea he wants to put it here. That's why he put or ileocolic, colo, and then esophageal. Clear?
Esophageal higher risk. Esophageal higher risk.
Esophageal and colon the higher risk, but small intestine has a low risk. Okay, next question.
Okay. 23-year-old man is undergoing an open appendectomy. The surgeons extend the incision medially and suddenly encounter troublesome bleeding. What is the best course of action? Apply topical hemostatic agent to the vessel, ligase the bleeding vessel, apply bipolar dicerm to the vessel, use monopolar dicerm to blend the setting to seal the vessel, or inject the area with dilute adrenaline. This is inferior gastric artery, so we should ligase the bleeding vessel. B is the answer.
So B is?
Answer, yes.
The answer. Okay, so you have open appendectomy and incision medially and suddenly encounter a troublesome bleeding. So what do you expect the bleeding coming from here?
Inferior gastric artery.
Exactly. Okay, you have injured the rectus sheath, and so this is the inferior gastric artery. So I think you will go for ligation of the vessel.
Yes.
Okay.
Okay.
Next question.
Sorry, we do double ligation in inferior gastric artery? Or...
Sorry?
We do double ligation?
Ligation. Why double ligation? Just ligate. You don't ask about double ligation. Why double ligation?
Because it makes anastomosis with superior.
Okay, it is already cut. You cut it. Yes, you will ligate both ends. Yes. You will ligate both ends.
Okay.
Okay. Who's next? Dr. Baida, Dr. Mustafa. Okay, Dr. Mustafa, then Dr. Baida.
Okay, a 72-year-old man undergoes a re-amputation for infection, complicating long-standing diabetes. What is the best method for healing the resultant wound? Compression, vacuum, split thickness, primary. It's an infection, so its graft is contraindicated, and compression also is contraindicated with long-standing diabetes, maybe have a peripheral vascular disease. So I think vacuum-assisted closure system.
Why?
Because primary closure is contraindicated, and also a graft is contraindicated because of the infection. Compression bandage is with the long-standing diabetes mostly have a peripheral vascular disease, so also contraindicated. So maybe it's a vacuum.
Exactly. I'm just want an explanation, not more.
Okay,
not more. When we do an amputation for toe or finger amputation for a diabetic patient, especially when it is infected, we don't do a graft, we don't do a primary closure, we don't do full thickness or split thickness graft. We do what is called vacuum assisted closure system to protect against the infection. Okay, Dr. Baida. And enhance granulation tissue, exactly. Yes, and absorb any exudate. Dr. Baida can go.
Okay. Which of the following surgical energy devices would be most appropriate for the dissection of posterior medial aspects of thyroid gland during thyroidectomy? Harmonic ACE, it is type of ultrasound guide diathermy. Monopolar diathermy in coagulation mode. Bipolar diathermy, COSA device. Argon plasma coagulation device. I think it's COSA device because it's ultrasound dependent. I'm not sure, but I am confused between bipolar diathermy and COSA device. But if I want to choose for open thyroidectomy, it's bipolar diathermy.
Exactly. Because device we use it, you have a question here for brain or a tumor from any lobe in the brain, you can call the COSA device, but for bipolar diathermy, use it for thyroid gland or for thyroidectomy, for ligation and cutting of the small vessels of the and the posteromedial place of the gland and attachment of the gland posteromedial for this section. Keep it bipolar diathermy, okay?
Okay.
Okay. Okay. Who's asking about a lipoma? Can answer this question. Incision of lipoma. Dr. Muhammad, تفضل.
A 34-year-old man has a tissue defect measuring 3 cm by 1 cm following an excision of a lipoma from scapula. What is the best option for managing the wound? Direct primary closure, delayed primary closure, pedicled skin graft, free flap, rotational flap. I think this clean wound, clean surgery with a small defect. So I think the best answer is direct primary closure.
Exactly. You remove the lipoma and 3 cm by 1 cm and then go for primary closure. Exactly. This, I think, this clear. Not, we don't do graft, we don't do flap, or we don't do delayed primary closure, there is no infection. This is a clean operation, so you go for primary closures. Thank you, Dr. Muhammad. Who is next? Okay, Dr. Muhammad, go for the next question again as you open your mic.
A 53-year-old lady undergoes a low resection for rectal cancer. The procedure is performed most appropriate of the abdominal wall, mass closure of the
should be أقطع Dr. Muhammad.
0 BDS closure of the abdomen.
دكتور محمد صوت بيقطع بس شوية. الو الو Is my voice clear? Anyone can open mic?
Yes, your voice is clear.
Yes,
Dr. Muhammad, you are out of. Okay, so can you, I didn't hear Dr. Muhammad which did choose. Anyone can answer?
Sorry, I was disconnected.
Okay, so Dr. Muhammad, which choice did you choose?
I think it is I think answer number 1.
Exactly. Use a PDS, mass closure of the, that's why I'm talking if I want to close, so I use it mass closure of the abdomen using one PDS. All here is mass closure, okay, but here is using nylon, no, using vicryl, no, using PDS. He said 20 PDS. I think this is very small for abdominal wall to close, midline incision, and 1 PDS is the best answer. And Jenkins rule, which uses this is 1 centimeter transverse, 1 centimeter cross, and then 1 centimeter close, and so on. This is the Jenkins law used for closure of the abdomen. Okay, here is 1 centimeter and 1 centimeter. This is the rule of closing. 1 centimeter bite here, 1 centimeter bite here, and 1 centimeter as a bridge. Okay. Yeah, some pharma question. Who can go for?
Yes.
Dr. Mahbub, تفضل.
Which of the following local anesthetics is not an amide type? Alingocane, xylocane, brocane, and Perilucane. The answer is C. It is not an amino type, it is ester type.
Exactly. You don't have any question, and I didn't sit and recall maybe one time. Just to go for local anesthetic. He tells you all local anesthetics are belonging to 2 categories: amino type or ester.
Ester type.
Ester type. Sorry. Amino to ester or amide to ester. Okay. This is the 2 types you have. All of them are amino to amide, except for procaine, which is amino to ester, and benzocaine. But keep this one in your mind, because in exam it will come with the same name. Procaine is the only one. It's amino ester type. Amino ester type. Okay. All of them are amino to amide. Okay. this question. Okay, this for Dr. Ayman.
Yes. A 56-year-old man is 8 days following a left hemicolectomy. He has developed a swinging pyrexia over the past 48 hours and has an alias clinically. What is the most appreciated investigation? I think we do abdominal scan, abdominal CT scan.
Okay, in pediatric, what did you do?
Still, I am junior in pediatric, doctor.
Okay, but in pediatric, I said, what did you do when you find a child with a swollen or red wound and abdominal distension?
Did the ultrasound.
You did ultrasound. But here in adult patient, and you doubt leakage, what you did?
CT.
CT scan. CT scan with contrast. Put it in your mind. In child, you don't rush for CT. In a child, you don't rush for CT for any leakage or any, you doubt any intra-abdominal collection. You just start with least harmful investigation and then go for CT if you can't confirm your diagnosis. But in adults, especially patients have a resection anastomosis or a colectomy or any resection of the bowel and you doubt for leakage, you go for abdominal CT with contrast. Okay?
Okay.
I was intended to you to answer this question because you answered the first one.
Thank you very much.
Okay, this easy question, who will go for it?
Yes.
Okay.
Which of the following suture has largest diameter?
Baby
It's D.
Yes, one proline, so 305060 and 0. So the smallest one is
880.
No, here in the choices.
Here 60.
60 polyproline. Okay, this asking about suction drains. Who will go for this question? Dr. Baida. Okay.
Okay. A 67-year-old lady undergoes a mastectomy and axillary node clearance for breast cancer. The surgeon decides to insert a drain to prevent the development of seroma. What is the most appropriate device to use? Okay. Closed section drainage system made of Proline, a closed section drainage system made of latex, passive drainage system made of Proline, insertion of penrose drain, use of wood closure system. So to overcome seroma, we need a closed section drainage by using Proline.
Okay, so you choose
A.
A. Okay, why is he choosing B and D?
B, because it's latex and it's most commonly used intra-abdominally, and the proline is most sensitive for like Radivac is sensitized by proline. And the passive drainage system made of proline, it's not a passive. We need only closed suction drainage.
Okay, exactly. Closed suction drain. We use it, and in practice we use Radivac for some wounds like this. Sometimes you put it for hernia, sometimes you put it for any bridal operation. You have a big lipoma in the abdominal wall, breast surgery. All of this we use a suction drain used from polyproline, like Radivac. Thank you, Dr. Baida. Who's next? Who can go for this question?
Yes.
Dr. Mahgoub, okay.
Okay, in which electrosurgical modality is the active electrolyte placed in direct contact with tissue and is characterized by low current and high voltage over a broad area. Blended current, cutting current, coagulation current, dissection, fulguration. Direct contact, low current and high voltage. I will go with cutting current. I'm not sure. Cutting current. B.
Direct contact.
Yes, direct contact and high voltage.
Low current, high voltage. Okay, anyone has different answer? Okay, so this is our last question today. I'll end our discussion by it. This is if you find this direct contact with tissue, okay, you will go for dissection. Okay, direct contact with tissue with low current, high voltage. Forget about this. Keep this word in your mind. Direct contact with tissue. You will use it as dissection. Okay.
Okay, just direct contact. Okay.
Okay, I'll make it easy for you. This is our table, and you have about 1 or 2 questions in the exam about this. I think only one question came in my exam. Okay, let's start with dissection and fulguration. Forget about the blend. You don't have any question about the blend action. Okay, this is a blend. This is a blend between coagulation and cutting. Okay, dissection, the active electrode is direct contact with the tissue. Clear?
Okay.
Fulguration, which is a spray. You know the spray or fulguration? You are working in the operation and you tell the nurse, make it spray, please. Or fulguration, please.
Yes.
So you held it away from the tissue.
Like in diabetic food, we use it.
Spray effect. Oh, sometimes if you want to coagulate, but from away, just make fulguration so you can burn an area or stop bleeding of an area or make coagulation for an area by fulguration. Okay, but you don't touch the tissue, you just 2 millimeters away from tissue and make this. So when you find away from tissue, you go for fulguration, and this is a spray effect, superficial tissue destruction. Okay, forget if you want to start to think about high voltage, low amplitude, low current, high voltage, both are high voltage. This is low current and this is low amplitude. You will be confused. Keep these two words in between. Keep these 2 words, please. Okay.
Okay.
Keep these 2 words. To be held away from tissue, our spray held away. This is fulguration. In direct contact with tissue, this is dissection. Clear?
Okay, clear.
Clear. Come for coagulation. Coagulation and cutting. Okay. Coagulation, modulated current. You'll find you are using modulated current with intermittent blah blah blah. Forget about modulated current. Okay. This will go for coagulation. Sinusoidal, non-modulated waveform, go for cutting. Sinusoidal, okay, non-modulated sinusoidal, go for cutting. Modulated current, intermittent, and he will tell long sentence, go for coagulation. Direct contact, go for dissection. Held away, go for fulguration. This is the 4 important. Clear?
Clear.
I think it's easy now. Blend, forget about it. He will not ask you about a blend. Alternating cutting and coagulation. He will ask you even on cutting or coagulation.
And it is most commonly used in taking polyp samples from colorectal disease.
The blend?
Yes.
Yes, maybe. Yes, cutting, coagulation, cutting, coagulation. Okay, clear. Then I think that's enough. Or you go for this a new question about diathermy. Okay, it's enough for today. Keep it enough for today. I think we finished almost half. It was 67 slideshow available for download. But after we finish, I'll download the recorded Zoom lecture. Okay, thank you. I'll close the record here. I think we are almost 2 hours. Thank you.